get started. Privileged to have Dr. Dan Matson here to give a talk on his research on uterine serous carcinoma. Dr. Matson did his MD and PhD at University of Virginia, and then did his residency and fellowship here at UW, and then spent some time in Dr. Resnick's lab working on GATA2, which is what we will talk about. So he extended that work from his research fellowship in Dr. Resnick's lab, and has in his independent position, he has now focused on the carcinoma. So that's what he's going to talk about. He has multiple collaborations with folks and we'll be discussing those collaborations as well. So, Dan?
Thanks for the chance to come and talk about our work. So one of the reasons I'm really excited to be here is because this has really been a wonderful collaboration with multiple investigators in your department. And I'm very interested to kind of get your opinion on our work. So
there's a bunch of people online, so just make sure, let's have somebody shout out that they can hear you.
So hopefully, if anybody is online, can just let me know that you can hear me in the chat. Yes, all right, thank you. And
I always like to check, because you got like 30 people online.
So we have one disclosure, so we're going to be discussing a topic or topics that are not yet adequately based on current science evidence and or clinical reasoning that falls outside the standard of care. All right, so I'm a hematopathologist. My postdoc training was in hematopoiesis, studying this transcription factor called GATA2. So this is a zinc finger transcription factor. We call it a pioneer factor because it's considered to be among the first to set down a naked chromatin and basically establish the kind of genetic programs that are going to be critical for what it's most known for, which is emergence of the hematopoietic system and the blood in the bone marrow, basically during development, and then maintenance of the blood in the bone marrow in adults. And another very great reason to study GATA2 is because there's very real clinical relevance. So there's a germline syndrome where patients are born with mutations in GATA2, and they develop a multitude of debilitating symptoms, but the worst of those is cancers of the bone marrow that, for which they have about 100% penetrance by the time they're adults. And we really still have very poor understanding of why these mutations lead to bone marrow cancers in these children. So the field sort of thinks of GATA2 as a hematopoietic transcription factor, but that's really not the case. It's important for the development and function of multiple organs. And one of those is actually in the uterus, where only a small number of studies have really been published looking at its function. But in the endometrium, it works with progesterone receptor and is critical for signaling PR-dependent programs. And actually, if you get rid of GATA2 just in the endometrium of a mouse, the mouse is infertile again because it basically can't decidralize. So I'm going to be talking about uterine cancer today, and one of the nice things about being in front of this audience is that I don't have to go into a long talk about why uterine cancer is such a significant problem. It's common and its incidence is increasing, and the outcomes really haven't significantly improved in quite some time. So because of the increase in incidence and the failure to improve outcomes, there's actually more women who are dying of uterine cancer now than there were a couple decades ago. And then another really bad feature of this neoplasm is the marked racial disparity in the outcomes, which are considered among the worst, if not the worst, across all cancers. And so Black women especially have much worse outcomes than white women, and that is not completely accounted for by socioeconomic factors. And so we really don't understand the racial disparity in the outcomes. A lot of these really bad facts about this cancer are actually not due to the most common histologic subtype of uterine cancer, which is the endometrioid, but caused by these less common types of uterine cancer, especially uterine serous carcinoma. So this cancer only accounts for about 10% of all uterine cancers, but is responsible for nearly 50% of deaths. The median age of diagnosis is 72 years, and its incidence is increasing quickly. So over about the past 20 years, the incidence of it has been increasing about 5% annually. And unlike endometrioid uterine cancer, the molecular pathogenesis of serous cancer is actually quite stereotyped. So there's essentially universal inactivation of TP53, which is the first hit. And then as it grows and basically becomes more aggressive, it develops this chromosomal instability, which we refer to as copy number high, and then it invades. And there's relatively few other recurrent molecular abnormalities. So in terms of the treatment of this cancer, the patients tend to fall into two main baskets. The first are the patients who present with metastatic USC at diagnosis, which is about 40% of them. They get debulking surgery, combination chemotherapy, and have very poor outcomes. However, a slim majority of these patients actually have what appears to be localized USC at diagnosis. And I'll talk about why I say appears to be. But basically, using our most sensitive imaging and other modalities, we cannot detect any USC outside of the uterus in these patients. So they essentially should be cured by surgical resection, by staging hysterectomy. But almost 30% of them will recur if they don't receive adjuvant chemoradiation therapy. And so the majority of these patients, even though they have no evidence of disease outside of the uterus, will get staging hysterectomy and receive chemoradiation. And given that the median age of diagnosis is 72 years and the chemo is combination paclitaxel carboplatin, there's relatively high morbidity. Yes, and so ideally, we would be able to risk stratify these patients for adjuvant chemotherapy. But at the moment, we really have no way to identify those patients with localized USC who are at high risk of recurrence so that we can target therapy. So if we could identify which of these low stage USC patients, which are about half of the new patients with this cancer, are at risk of recurrence, then we could potentially not give adjuvant therapy to the patients who we know are not going to recur. And we could ensure that we, when possible, give adjuvant therapy to those who are at high risk of recurrence. This would be theorized to greatly reduce therapy-related morbidity and also would likely improve outcomes. And this is basically going to be the crux of what I'm going to show you today. So we have developed a monoclonal antibody against GATA2. It's the only monoclonal antibody that can routinely detect this factor in human tissue sections using routine surgical pathology techniques. And this monoclonal antibody detects high GATA2 expression in basically a third of patients with localized USC, with FIGO stage 1 USC. And in every patient we've identified with high GATA2 expression, 0 have recurred. And they have 100% cancer-related survival. And that is significantly better than approximately 2/3 of the patients who have low GATA2, mostly lost GATA2 expression, who are the patients that tend to recur and have poor outcomes. And I'm going to end with this slide, but I'll just show it to you now. So the question is, well, is it because these patients don't recur because they respond to adjuvant therapy, or because they were truly localized disease that was cured by staging hysterectomy? And so we have a multi-institutional cohort of patients who had FIGO stage 1 USC, who for various reasons never received any adjuvant therapy. They did not receive any neoadjuvant therapy, and only one patient in the entire cohort received any kind of radiotherapy. And the GATA2 high patients 0 of them have recurred. and they have almost 100% overall survival, and both of those are significantly better than the patients with low GATA2 tumors. So these are kind of my takeaway points from the presentation. If you take nothing else away, I'll just put these right up front. We have a custom anti-GATA2 monoclonal. We can produce it at industrial scales indefinitely. We've been doing this at multiple institutions, and it can be read simply by surgical pathologists as they would read out ER, PR, and or other stains. I'll show you some mechanistic data demonstrating that we can take patient-derived cell lines from USC tumors, including some that we've isolated from patients here at UW. And if we deplete GATA2 in these tumors, it promotes USC invasion in vitro. And with the help of Lisa Baroulet and other members of your department, we are proposing that a trial in which we hope to demonstrate that GATA2 high patients, which are about a third of the patients with localized disease, may benefit from basically complete dose de-escalation and only close clinical follow-up. And that high-risk patients who are GATA2 low tumors should be, if possible, triaged to adjuvant chemotherapy, because they're the ones who are most at risk to recur and would benefit from risk-reducing adjuvant therapy. All right, so let's back up all the way to the beginning now. So when I started my lab, I was working on we're still working on GATA2 in hematopoiesis, so that's always been sort of the primary project in my lab. And no one's ever been able to measure GATA2 in patient tissues because neither companies nor academic investigators have been able to make antibodies against GATA2 that can identify it in tissue sections. And so when I started my lab, we made monoclonals, and what that enabled us to do was basically look at GATA2 wherever we wanted, very cheaply. Stephanie McGregor, who is a gynecologic pathologist at UW, had already made a large tissue microarray of uterine cancers. We saw in the literature that GATA2 was expressed in the uterus. We knew it was related to the development of malignancy in the bone marrow. And so basically, we just decided to stain her uterine cancer TMA. So this TMA contains 70 USC patients, and it's meant to be a representative cross-section of the typical, USC cohort that you would see in the USA. And to kind of emphasize this, we did something called population validation, where we took 1,700 patients from the SEER database from 2018 to 2021, and we statistically compared all of them to this cohort. And essentially, this cohort is highly statistically similar to just a typical cross-section of the people in the USA who present with USC, with the exception that this cohort is much less racially diverse than the USA as a whole. Basically, there's a much higher number of white patients in our UW cohort than there is nationally. And when we perform the GATA2 IHC, it's actually very simple and can usually be read out in a matter of seconds, honestly. So we just look at the tumor nuclei and just count the number that are positive and just ask what % of the tumor cells are positive. And most of them, as you can see here in this histogram, are negative, and so it goes pretty quickly. The ones that are positive are usually quite positive, and so again, that scoring is usually pretty quick. And we established this cutoff of 15% based on the clinical outcomes that I'm going to talk about. And so in terms of scoring this IHC, we've done it at multiple institutions now, including just sending them the antibody and letting them optimize it and score it without any input from us. And we've had the exact same results in terms of being able to predict the clinical outcomes. And it's really only a small subset of cases where the pathologist might actually have to count and go nuclei by nuclei to get the percentage. If we separate the tumors by GATA2 high and GATA2 low using the 15% cutoff, the GATA2 high and GATA2 low cohorts have the same patient age. The tumor size is the same, so the primary tumor size is the same. But what we quickly found was that the high GATA2 tumors were much lower stage. And even though it's a little difficult to appreciate from the way the data is spread here, most of the GATA2 high tumors were essentially completely non-invasive. And so this is just, in this cohort, the statistical differences between the high GATA2 and the low GATA2 cohort. The other interesting thing is the hormone receptor expression. So the ones that are GATA2 high tend to have retained hormone receptor expression, which is, of course, is very interesting, especially given that PR is known to work with GATA2 in the benign endometrium. But in general, the types of things that we would think about in terms of prognosticating how well the patients may do with this cancer, they're mostly the same with the exception of the myometrial invasion. And this is what we saw in this initial cohort. So basically the GATA2 high tumors had almost 100% cancer-related and overall survival, which was significantly better than the patients who were GATA2 low. So as I had mentioned, the patients that are GATA2 high in this initial cohort, which is all stages, they tended to be low stage. And so it kind of makes sense that they would tend to do better. So we were curious if in the metastatic tumors, the FIGO stage 3 and 4, if we could also see this relationship. But in our initial cohort, there were very few GATA2 high tumors that were actually high stage. And so in order to specifically look at this question of how well they would do in the metastatic setting, we collaborated with Pei Hui at Yale to get another cohort of 36 USC patients who were treated at Yale, who the vast majority of them have high stage disease. And then to look more closely at the patients with the low stage disease, mostly FIGO 1. So patients where the disease is localized to the uterus. We also built out in collaboration with Lisa Barouet and Emily Chu, another cohort of patients treated at UW who just have FIGO stage 1 disease. Finally, we wanted to get an additional extra-institutional cohort of these low stage FIGO 1 patients. So we collaborated with Britt Erickson and Ruth Baker at the University of Minnesota to build a cohort of just FIGO stage 1A non-invasive USCs. So for those of you who are not familiar with the behavior of this neoplasm in the localized setting, even a subset of the FIGO 1A non-invasive patients recur, which obviously makes it very difficult to triage them for adjuvant therapy. And so we thought this was a particularly relevant cohort if our GATA2 test could predict recurrence in the patients. For this UMN cohort, we also wanted to see how well this antibody could be scored independent of any kind of intervention or training from us. So we literally just sent the monoclonal to their histology core, told them to optimize its staining on just benign endometrial tissue, and then asked the pathologist to simply score the percent of the GATA2 expression in the tumor, the number of positive nuclei, and we didn't provide them any additional input. The pathologists scored the tumors blindly, so they had no idea what the clinical outcome was of the tumors they were scoring. And I was the first one to basically connect their clinical information with the GATA2 expression. And so these 4 cohorts, Stephanie's, Lisa's, Pei's, and Dr. Erickson's, are about 200 total USCs and 127 FIGO stage 1 USCs. And here is just a summary of that. So first, in the metastatic setting, we found that there was basically no predictive value of survival in the setting of metastatic high stage disease. And so this really suggested that there was no difference in response to chemotherapy due to the GATA2 expression, because the survival of these high stage patients is most dependent on their response to adjuvant chemotherapy. And to kind of drive this home, we took multiple patient-derived uterine serous carcinoma cell lines. We depleted GATA2 using 2 different siRNAs, and we measured their ability to respond to carboplatin paclitaxel and combination carboplatin paclitaxel. And we basically see no difference. So this is important, suggests that basically there's no difference in response to chemotherapy based on the GATA2 expression. So with that in mind, we really focused the rest of this study on about the 50% of patients who present with FIGO stage 1 USC. And so these are where these patients are coming from in terms of these 4 cohorts. And the UMN is somewhat unique in that all of the patients from this cohort are FIGO 1A non-invasive. And so this is what this combined cohort looks like. It's in terms of the population validation, it's very similar to sort of a basket of FIGO stage 1 patients, slightly enriched for FIGO 1A non-invasive because of the UMN cohort. And again, it's a higher number of white patients than the population level in terms of the racial diversity. So let's look at the GATA2 expression in just the FIGO 1 patients. Almost exactly 33% of them are GATA2 high. In terms of the patient age and the tumor size between the GATA2 high and the GATA2 low patients, there is absolutely no difference. And if we look at all of these different elements between the GATA2 high and the GATA2 low cohort in FIGO stage 1, there's no statistical difference across all these metrics. So we were a little surprised that there was no difference in the myometrial invasion, but it turns out this is mostly because of the fact that we're looking at a stage where many of the tumors are non-invasive. And so essentially we have a reduced dynamic range to detect this difference in myometrial invasion. And the PR expression is close to being statistically significant, but not quite. And so this is what the curves look like. So the patients who are FIGO 1, so in this case, it's about 40 patients who are GATA2 high. We have yet to see a single patient recur. They all have 100% cancer-related survival, and the overall survival is close to being statistically significant as well. So we were, I was honestly shocked to see this data. And I am still searching for ways to explain this because it seems amazing that we can have 100% prediction of recurrence. But we decided to basically chase this result, even though my lab focuses on hematopoiesis, and bring these cancers into my lab and essentially make it 50% focus of my research. So we acquired patient-derived uterine serous carcinoma cell lines from Alessandro Santin at Yale. These are among the only cell lines that really have been validated to definitely be uterine serous carcinoma. Many of the classic ones, unfortunately, it's unclear exactly what type of histologic subtype they were isolated from. And so we have been using these ARC1 and ARC2 cells, but we also have isolated about 10 cell lines from patients who have been treated here at UW. One of the first questions that we had was when this GATA2 loss occurred in the pathogenesis of these tumors. And in asking this question, it's beneficial to remember that the molecular pathogenesis of the cancer is highly stereotyped. So there's foundational inactivation of p53 and then acquisition of this copy number high. And so we were curious if at what point in basically that pathway the GATA2 loss occurred. So essentially all of the patients had inactivation of p53, something like 95%, which is expected. And the GATA2 spread was between 0 and 100%. So we knew that the GATA2 loss was occurring after inactivation of p53. But we were curious about the copy number, and so we worked with the State Lab of Hygiene to look at copy number FISH, which is the gold standard for measuring chromosome copy number. And we found that there was no difference in basically copy number or SYN between the GATA2 high and the GATA2 low patients. And so we think that the GATA2 loss occurs after these events and is probably, at least in terms of what's known about the pathogenesis of this cancer, the most proximal sort of marker of molecular events that may trigger invasion in this cancer. So basically, these patients, they have the same amount of PP3 inactivation, the same high copy number, but if they have the GATA2, they are largely non-invasive. So using these uterine serous carcinoma cell lines, we can routinely deplete GATA2. So first off, they all express, we can detect GATA2 using our monoclonal in all of these cell lines to various degrees. So some of them have low GATA2, some of them have high, which kind of mimics the patient data. And we can use siRNAs. So we have two different unique pools of siRNAs that can both deplete GATA2. And we also have another SH-GATA2 shRNA, which is doxycycline inducible. So we can make stable lines and put them into animals or do sort of larger ex vivo studies with that. So we have sort of multiple unique approaches in which we can deplete GATA2 into cells. And we've also shown using multiple approaches that if we do this, it leads to increased invasion. So we started with sort of these very simple Boyden chamber assays where there's not very much serum in the top basket, and that's where you put your cells. And then there's a lot of serum in the media and the bottom, but in order for the cells to get there, they have to go through matrigel and through a porous membrane. And if we deplete the GATA2 in multiple cell lines, we rapidly see that the cells are much more able to invade within 24 hours. Then we worked with Maria Virambrales Munoz, who's an investigator in this department, and used her microfluidic system, using the tissue native hydrogel matrix. And in her lab, she was able to take these cells, develop tumor spheroids, with our SH-GATA2, we can simply add doxycycline to the media that these spheroids are in, and they will rapidly be depleted of GATA2. And if she puts these tumors into this tissue native hydrogel matrix and depletes GATA2 and asks how quickly they can basically spread out in all directions, the ones that lose GATA2 rapidly become much more invasive. And we've since developed with Maria and other investigators even more sort of tissue relevant assays, and this result is extremely consistent. So we began asking, well, what are the molecular mechanisms through which GATA2 may be acting to cause this increase in invasion? It's a transcription factor, and so it binds to different sites in the genome and basically activates the expression of target genes. So in theory, it's activating the expression of some target gene, which is then going and contributing to this invasive phenotype. So we performed RNA-seq and ChIP-seq, and what this in our patient-derived cells before and after GATA2 depletion, and what this told us, and for the RNA-seq, was which genes change after GATA2 loss. So that is the setting in which these tumors invade. So we should be able to hopefully see the expression changes in that setting. That might give us a clue as to what pathways are being upregulated to cause invasion. And then the GATA2 ChIP-seq is going to tell us what parts of the genome the GATA2 factor is actually bound to, and it binds nearby the genes that it regulates. And so if we combine these two data sets, we can enrich for factors in which GATA2 binds nearby the gene and the gene's expression is changed after loss of GATA2, which suggests that it's directly regulated by GATA2. This is exactly what we did. And so we've begun identifying GATA2 target genes in this cancer, which contribute to the increased invasion. The first one that we identified is SYN3B. So this is a map of the gene locus. And right in the proximal promoter region, we have this big occupancy by GATA2. So we showed that if we depleted GATA2 in the cell lines, we also got depleted SYN3B protein by Western blot. And if we depleted SYN3B, so we sort of bypass GATA2, go straight for the GATA2 target and deplete that, then we also see increased invasion. So we think we know that it's more than just this one factor, SYN3B, and we actually have multiple candidate targets that we're looking at, including some which we can inhibit with small molecules, which of course is very enticing from a potential clinical intervention standpoint. But this is kind of a model for how we've been going forward to identify and start characterizing these GATA2 targets. So I mentioned in the beginning that we hope that the patients who have low stage and are high GATA2, so it's about 30%, 33% of the FIGO stage 1 patients, they might potentially be cured by surgery and not need adjuvant chemotherapy. In order to establish that, obviously, it would take a prospective trial. But one thing that we can do is retrospectively try to identify patients who, for various reasons, were unable to receive adjuvant therapy. And there's not a lot of them because most patients with this cancer do get adjuvant therapy. But we did find 24 patients, which are from a combination of UW and Minnesota, who were unable to or chose not to, with their clinician, receive adjuvant therapy. 14 of them are GATA2 high and 10 of them are GATA2 low. And here is just sort of what this cohort looks like. So no neoadjuvant therapy, no adjuvant chemotherapy, and a subset of them did get vaginal cuff radiation, and one of them got external beam radiation. But if we compare, if we ask basically in what GATA2 cohorts those patients fell, there's no statistical difference between the GATA2 high and the GATA2 low patients. And this is the chart that I showed you earlier. So essentially the GATA2 high patients, we have yet to see any of them recur. And not surprisingly, given that they don't recur, they have much better overall survival compared to the GATA2 low cohort. So we submitted this manuscript and it was reviewed overall very favorably. I'm getting ready to resubmit it potentially today. So we're very excited about that. And what we are proposing is that instead of the current NCCN guidelines, where the large majority of these FIGO-1A patients, including many of these FIGO-1A non-invasive patients, are now triaged to chemoradiation, adjuvant chemotherapy and radiation to reduce their risk of recurrence, that we may be able to use a GATA2 guided personalized medicine approach to the FIGO, starting with the FIGO-1 patients, specifically starting with the FIGO-1A non-invasive cohort, where the patients who are GATA2 high can simply undergo close observation by their clinician after staging hysterectomy. And the patients who are GATA2 low, those are the patients who seem to be at risk of recurrence. And so if possible, we would suggest that they be considered for risk-reducing adjuvant therapy. So for the future directions, we have been very fortunate to work with Lisa very early, and she and her fellow Julia have really been instrumental in helping kind of guide this work so that it may be prepared for potential prospective clinical trials. We're very excited to work towards moving in that direction as the data sort of guides us. And in addition, we now have a major focus in the lab, which has been funded by the American Cancer Society and the V Foundation, to basically start identifying the molecular mechanisms that cause loss of GATA2 in these tumors, and then kind of build out a library of the USC target genes, which are causing increased invasion when the GATA2 is lost. We're also working with Pam Krieger in my department, who works on serous ovarian cancer. And so we, of course, are interested in the ovarian serous carcinoma as well, because the molecular pathogenesis is extremely similar. And that is something that we are actively looking at as sort of the effort in my lab permits and access to collaborators permits. And as part of this, we are working towards generating an animal model of FIGO stage 1 USC. And so when I moved into this field, I was kind of surprised that there weren't a lot of very good models of localized USC animal models. So most of the animal models for this cancer, they sort of spray the tumor cells into the abdominal cavity of the mice. And for many of those studies, you're looking at the ability of the tumor cells to implant and the response of the tumor cells to chemotherapy. The GATA2 doesn't seem to really have a role in either of those. So we're really looking for a model of direct local invasion. And so what we have been able to do working with the veterinary staff here at UW is actually implant these tumors using a transvaginal route into mice, into the actual uterine cavity of live mice. And we believe that this is going to essentially serve as perhaps the first really good model of localized USC, which does not involve basically perturbation of the uterine lining. So that is something that we have working in the lab now. And with some additional optimization, we're hoping to sort of start those studies within the next 3 to 4 months. And so with that, I'm happy to take any questions. I'm very interested to get your take on it. And we have a tremendous number of collaborators. I'm a hematopathologist. My lab started working on hematopoiesis, which is still one of the focuses of my group. And so none of this, I mean, there's no way this would have been possible without all of these collaborators. And I just really want to thank everybody here and our external collaborators at Yale and University of Minnesota. So thank you, and I'm happy to take any questions.
Yeah, thank you so much. This is super exciting and really appreciate you coming and presenting it in such a sort of clear way for all of us. One of the questions I have, I assume this work has been done over many years, and I'm just wondering whether all of these specimens have been analyzed with the current molecular classifications. I mean, they're 95% p53 variant, they're copy number high, but I'm just wondering if you've also, you know, like really sorted out where they sit with the current, you know, molecular classification staging, because in the contemporary sense, you know, the field's moving that way. And I was just curious about that. And I'm super happy to hear that you're you know, sort of thinking about looking at GATA in the Serous. Just fabulous work, and thank you so much. Thanks.
Yeah, we know that this field is moving towards a molecular classification system for the endometrial cancers. And so I don't have the data with me today, but we actually have data to suggest that this will extend to all p53 mutated copy number high tumors, including high-grade endometrioid tumors. What would in the histologic subtype be called, you know, grade 3 endometrioid. Many of those, as you know, are p53 activated and they're copy number high and clinically behave like Serous. And we have a smaller cohort of those, but we see the same effect of the GATA2. And so moving forward, we expect this to apply to that entire molecular cohort. In terms of what we've done to sort of molecularly validate this cohort, the UW2, the one that Lisa and Emily assembled, that is a largely current, or at least like within, I believe, the last 3 or 4 to 5 year cohort. And then for Stephanie's cohort, she's done quite extensive molecular and histologic subtyping of those tumors. And so those, including the data we have from the state lab, definitely would fall under the p53 mutated copy number column. Yeah.
I love this talk. You're just so amazing. It's so exciting. So, and I remember when you came to me with this data and you're like, is this a big deal? And I'm like, yes, Dan Matson, this is a big deal. I think what Ellen's trying to get at is, do you know if any of these are poly-mutated also?
Oh, I see. We don't know if they're poly-mutated. So we expect, like from the published cohorts in which they've taken these high-grade tumors and done the POLE sequencing, we expect that if there probably are a small number of them. We suspect like less than 10, maybe in our final phase 1 cohort that may be POLE mutated, based on some of the larger published studies in which they've basically gone hunting for POLE mutated tumors in tumors that were otherwise classified as serous.
Yeah, it's true. I was interested in what's going on with POLE, but I'm also interested in, you know, what does GATA mean in other histologies? I mean, this just opens up all kinds of questions, so just fabulous. But thanks for pointing that out, Lisa.
Yeah, great work. When you say P53 inactivation, have you figured out what the mutation is? And because there's so many mutations in P53. Not all of them are inactivated. So have you looked at what mutation it is and potentially what the effect of that mutation is on P53 activity?
Yeah, we haven't done the P53 sequencing, but the IHC is sort of thought to be like a readout of the type of P53 mutation. It's obviously not perfect, but that's sort of the data that we've been going on, and so we expect that like 95% of them are definitely P53 mutated based on the IHC readout, but haven't been able to do the genomic sequencing to figure out what those mutations are. Yeah. What we would like to do is get access to the TCGA cohort and do GATA2 staining on those. Unfortunately, the RNA level of GATA2 is not predictive, so that would be great if we go into the TCGA, look at the GATA2 expression, and then correlate that with the P53 mutations. But the RNA is not predictive of what the actual protein levels are, and they were unable to detect GATA2 using their mass spec in the TCGA for technical reasons, basically. And so we can't do that using the publicly available cohort right now. All right, thanks, appreciate it. And,
And I think the CME code is 24 to 0.